Warm welcome to Teatro 1 for this session on knocking down mitral regurgitation to improve outcomes. Early is better, but better late than never. Come to the session if you want to learn about and discuss about the role of the COAPT trial evidence of durability of MR reduction with clinical and outcome benefits, to understand the patient selection of suitable patients to achieve durable results, to help in selecting patients for a CE Mark toolbox of repair or replacement, and to learn how to use the latest real-world registry evidence to understand the safety and efficacy of mitral TEER. It's my great pleasure to chair this session. My name is Rolf Stefan von Bardeleben from Mainz, Germany, and I'm chairing this together with my friend and a pioneer in this therapy, Francesco Maisano from Milano. We have two women here on the left-hand side where we start with that almost need no introduction. It's Mariana Adamo from Brescia, Italy, and Alison Duncan from London, UK. And on my right-hand side, I have, of course, Greg Stone from New York, Georg Nikenik from Bonn, the University of Bonn, and we have a chat master, which is Sondos Samargandi, who will lead you and interact with you with the questions. And without further ado, I'd like to invite Greg Stone now to give his first presentation on the COAPT trial. Greg, please.
Thank you, Stefan. So it's really a pleasure to give you a synthesis of what we've learned from 5 years of COAPT and how important MR reduction is in patients with heart failure and secondary mitral regurgitation, my relevant disclosures. So I think everyone by now knows that COAPT was a 614-patient, parallel-controlled, open-label, multi-center trial in patients with heart failure and severe mitral regurgitation who importantly remain symptomatic despite being on all best Class 1 guideline-directed medical therapies and cardiac resynchronization therapy if appropriate. And those patients then were randomized 1-to-1 to the MitraClip plus medical therapy versus continued medical therapy alone. And the primary effectiveness endpoint was all heart failure hospitalizations through 5-year follow-up. Well, actually, 2-year follow-up was the primary endpoint, and then we followed them now for 5 years. And you could see that immediately after randomization and treatment with the MitraClip, the patients felt immediately better, their exercise improved, and they were much less likely to be hospitalized for heart failure. And the curves really spread for the first 3 years or so. I'll talk about why they were parallel from 3 to 5 years in a minute. But the bottom line is at the end of the 5 years, there were 447 total heart failure admissions in the control group, 314 in the MitraClip group. This was about a 47% reduction. So setting really a new standard of care in functional MR. And importantly, and we were talking about this in the last session, the MitraClip was extraordinarily safe. It's one of the safest procedures we do in the cath lab. We had a primary safety outcome that was agreed upon with FDA, which is a composite of device-specific events and then severe progressive heart failure requiring either an LVAD or heart transplant. And this occurred in only 3.3% of patients at 12 months, which was much less than the accepted allowed safety outcome of 12.5%. But importantly, when we follow these patients out to 6 months, 60 months, 5 years, if you look at the device-specific events, there were only 4 in the MitraClip-treated patients, 1.4%, and they all occurred within 30 days. So one, extremely infrequent to have device-specific events, and when they occur, they all occur very, very early. We had 2 cases of single leaflet device attachments, 1 device embolization, and 1 other complication. So very, very safe procedure. In addition, by reducing left ventricular pressure and volumes, you could see that we also reduced mortality. And again, before crossovers, the mortality curves were continuing to diverge. They don't diverge immediately. Unlike the heart failure hospitalizations, it takes some time for the pressure reduction to affect mortality, but there's a definite reduction in mortality, overall 28% relative reduction, about a 10% absolute reduction in mortality, so a number needed to treat of about 10 patients to save 1 life. Death or heart failure hospitalization similarly reduced by almost 50%. And when we look at all of the pre-specified endpoints we had, they, within the patients we enrolled in the trial, there was very consistent results, whether the patients were young or old, male or female, whether they were low surgical risk or high surgical risk, higher or lower left ventricular ejection fraction, prior CRT or not, et cetera. They really all benefited. So we did note that after 2 to 3 years, the curve somewhat became parallel, and the real reason was this was because of a protocol-specific process where at 2 years, the patients who survived were allowed to, in the control arm, if they still had severe MR and still were symptomatic, they were allowed to receive the MitraClip paid for by the study. And about 45% of patients in the control arm did that, who were alive at 2 years. Notably, half of the patients in the control arm had died by 2 years and couldn't take advantage of that therapy, but of the ones who did survive, 45% did. And if you look at now in this interesting curve, in the green, we have the originally randomized MitraClip group. In the blue, we have the originally randomized control group, that's medical therapy alone, but we took the patients out at the time of crossovers, most of which were around 2 years. And the orange is the patients who did cross over from the medical therapy group with their time. It's a variable time to cross over, and we reset their time to crossovers at time 0. And so you could see that if the patients in the medical therapy group did survive to receive a MitraClip crossover, they almost immediately achieved the success rate and the effectiveness rate of the original MitraClip assigned group. So the point being here, half of those patients had died, which was a real shame that we had to learn from this trial, but it's never too late to treat patients with chronic heart failure and severe mitral regurgitation. So we need to identify these patients as early as possible, not dawdle, treat them before they die and have more events, but then whenever we do treat them, even if they've had heart failure for 10 years, we can expect their improvement. And all of this really was underlined by the marked reduction in mitral regurgitation with the MitraClip. And of course, you know, the MitraClip's getting better and better. We use the 1st generation device here. Now with the 4th generation device, you can expect 1+ or less MR in about 80% of patients. But you know, the MitraClip, we didn't really even realize this at the beginning of the procedure, treats the underlying pathophysiologic derangement of the mitral valve in functional MR, and that's lack of coaptation. So the clip recoapts the leaflets. So unless you get a single leaflet device attachment, you know, you're going to continue to decrease mitral regurgitation effectively throughout the whole procedure. And if you look here at this curve, this is every time through 5 years we measured mitral regurgitation at a core laboratory, and I just put the numbers here of the recurrent severe 3 to 4+ MR, and you can see it's about 5% or less at all time periods. So basically, this is a durable procedure, and as we've shown and published before, it's the reduction in MR that leads to these improved outcomes. So we concluded that in heart failure patients with severe secondary MR who remained symptomatic despite optimal medical therapy, TEER with the MitraClip was safe, reduced the rate of heart failure hospitalizations, and improved survival during 5-year follow-up, despite allowing a lot of crossovers. These outcomes were consistent across all pre-specified subgroups, regardless of age, sex, MR severity, surgical risk, etc. The symptomatic status was also improved throughout the 5-year follow-up, and the MitraClip treatment provided durable repair of MR. The prognosis of those 45% of control group patients who crossed over at about 2 years was substantially improved, similar to had we treated them with the MitraClip 2 years earlier. But unfortunately, nearly half of the control group patients had died before, even while waiting for 2 years to become eligible for crossovers. This clearly points out that heart failure patients appropriate for TEER with the MitraClip should be identified and considered for treatment as early as possible. And lastly, I was asked, why did COAPT succeed where other trials in the space failed? We thought about this a lot. And first of all, I think we were very careful to enroll the patients who were most likely to benefit. And those are whose patients whose prognosis was really dominated in large part by the severity of the MR. So it was heart failure with decreased LVEF with severe MR, both disproportionate and proportionate, with the severity of the MR strongly contributing to the prognosis, but not end-stage left ventricular dysfunction, the patients who may not have benefited. We judiciously excluded other select conditions such as severe RV dysfunction or shock, where that would have dominated their prognosis. And then there were the rigorous trial processes, core lab requiring, confirming that we had severe MR at baseline, the central eligibility committee mandating that all patients were on maximally tolerated GDMT so that they could not increase their medical therapy during follow-up because that could have poisoned the trial. We had highly trained operators who had been using the MitraClip for 10 10 years prior to putting it into this trial. And again, I want to really thank the investigators and Abbott because we persisted. The trial enrollment was about 4.5 years, but we persisted. We got this trial done, the largest trial in the mitral valve space, and all of this led to the great success of COAPT. Thank you very much.
Thank you.
Thank you.
Thank you so much, Greg. I think we should acknowledge 3 people in the history of transcatheter edge-to-edge: Alfieri, who invented the Alfieri stitch; Ted Feldman, who did the first case, and Sabelkar maybe, but also importantly, Greg Stone, who has been able, first time, to demonstrate a survival benefit in functional MR. I mean, this is not for granted. It's been my task for 20 years. I always failed. Thank you. Now, but in your data, it's clear that there are 2 components. One component is patient selection. The other component is effective reduction of MR. And this is now the second portion of the discussion. We will see 2 cases with different characteristics, treated in different ways. And I think the first will be presented by here, Alison Duncan. Here.
No problem. So patient A is a 67-year-old gentleman with ischemic cardiomyopathy who'd had previous cardiopulmonary bypass grafting about 20 years ago. He has biventricular impairment, has an ICD implantation and previous VT ablation. He's currently in sinus rhythm, but he does have comorbidities of chronic kidney disease and obstructive sleep apnea. He was admitted to our hospital on intravenous diuretics to offload him. He was also taking heart failure modifying medication in terms of bisoprolol and eplerenone. He, prior to admission, had such a low blood pressure that his nitrates and his ACE inhibitors were discontinued. He was currently in NYHA class 3 with a raised BMP. He had previously had an ITU admission requiring IV diuretics for significant pulmonary edema. That was treated. He was discharged home but was readmitted with only 3 or 4 weeks later with this episode of pulmonary edema, a further heart failure admission, and his current 6-minute walk test was only 45 meters.
So on the right side, we have the patient B, who is a 72-year-old man with a heart failure with reduced ejection fraction, a dilated cardiomyopathy, and without coronary artery disease. Among comorbidities, permanent atrial fibrillation, a moderate chronic kidney disease, a moderate COPD. And in the clinical history also, multiple previous heart failure hospitalizations despite a fully optimized medical therapy for FRF, including all the pharmacological treatments currently indicated, and also including a high dose of furosemide. And he came to our attention because of a worsening of heart failure symptoms in class 3 with elevated levels of NT-proBNP, and with an impaired functional status and the quality of life.
So we're just going to go through the 2 patients' echoes. So patient A came with an ejection fraction of 35% in the presence of significant mitral regurgitation. His LV was dilated with an end systolic dimension particular of 45 millimeters. The EROA quantified as severe with an EROA of over 100 millimeters squared. His right ventricle was impaired with a TAPSE of 16, and he had significant pulmonary arterial hypertension with a pulmonary pressures of over 100 millimeters of mercury in the context of concurrent severe tricuspid regurgitation.
On the other end, patient B had a severe left ventricular ejection fraction, 36% of ejection fraction, a very large left ventricle, severe mitral regurgitation. EROA was probably underestimated because of the shape of the jet, but a normal right side with a normal right ventricular function and no pulmonary hypertension and moderate TR.
So patient A, in summary, was a 67-year-old gentleman with severe LV dysfunction, advanced heart failure, a Euro score of 21% and an STM PROM score of 6.2%. He underwent some other further investigations with a right heart catheter, which gave pulmonary systolic right ventricular pressures of 60 millimeters of mercury, an enormous V wave of 59 with a mean wedge pressure of 27 millimeters of mercury, a cardiac index of 2.3, a transpulmonary gradient of 10, and PVR of 1.9. His angiogram showed a patent lemur graft and one patent vein graft, and on his MRI he had some non-viable segments in the infralateral and inferior septum.
To summarize, patient B is a 72-year-old man with a FRF, severe left ventricular dysfunction and dilation, severe functional mitral regurgitation, and a high surgical risk, mainly related to the comorbidities, but also to the advanced ventricular disease.
Excellent. So it looks like we need to understand these two patients, what to do, and we have a poll from the audience. So how would you treat these patients? There are 4 options. How do they vote? You know, by raising hands? How is the vote? Anybody knows? No. Okay, raising hands. Okay. You have
It's
the app.
in the app.
Ah,
It's in the app,
fantastic.
electronic.
Thank
You
you.
get the
I didn't know
results
that.
at the end.
Okay, so 2 patients. Patient A, I remind you, because it's a bit difficult to remember. For patient A, I don't like him. You know, very tethered, posterior leaflet, a lot of MR. The other one, less MR and less tethered posterior leaflet. So would be both cases for repair, both cases for replacement. First, A is the one with more tethering, correct? Repair and the second replacement, or first replacement, second repair. Okay, so you think about it, and in the meanwhile, we may discuss here. You know, I tell you, I don't want to treat patient A. You know, if I can choose patient, I choose patient B. But you know, just I send you the other guys. What do you think? So let's start with the very first question to Greg, because you know I think that would be which one of these two is any one of these 2 patients coming into COAPT?
Yeah, so, you know, patient B is a classic COAPT patient. I mean, you know, did not have major comorbidities, you know, had moderate to high risk, a very nice, you know, 3+ to 4+ MR jet, looked very clippable, had very good anatomy, and did not have any exclusion criteria. And I think that, you know, today, for me, patient B would definitely get the mitral clip. Patient A is much more complex, right? It's a much higher risk patient. There were several comorbidities that would have excluded patient A from COAPT. The fact that the patient was frequently readmitted in a short period of time and was really clinically unstable. We primarily in COAPT put, you know, patients who, you know, could stay stable on a stable regimen of medications for 4 weeks. There were at some point where that patient had pulmonary pressures over 100 millimeters of mercury, but then at other times where it looked like it came down to about 60 millimeters of mercury, so it seemed like it was very vasoreactive. So I probably wouldn't exclude the patient for that reason. And it wasn't clear to me that the anatomy was amenable to the mitral clip. I mean, there really was a very wide coaptation width, and I think you'd be less sure of getting a good result. So I think for, you know, for patient A, I think you could try a repair and see if in the lab you were getting a good result before you release the clips, or definitely go right to replacement.
So quick answer from all around the table. So Georg?
I agree more or less with Craig. Patient B is a perfect candidate.
More or less, which is?
Candidate for a clip. And patient A, I would also think I haven't seen really an absolute anatomical contraindication against a repair. It's going to be very challenging, but you could try, but you have to decide after the first clip, because otherwise it's going to be spoiled and you don't have a good option. I mean, you can do some complicated measures afterwards, but patient A would be maybe a better candidate for replacement.
Stefan?
Yeah, I totally agree to everything that has been said. We saw an extensive overriding anterior leaflet, very much tethered posterior leaflet, so different levels also to engage the leaflets. Try to do it is always possible. The comorbidities were extensive, so we had 60 millimeters mercury right ventricular pressure. We had a lot of situations and a higher Euro score. So this would be a patient, if anatomically suitable, that would benefit from a safety standpoint from the clip. But I agree that replacement may be the best first answer.
Although high pulmonary pressure, because it's free flow MR. Saunders?
I cannot agree more. Like as
you
we
agree
said.
as well.
Agree,
So
yeah.
everybody agrees. That's
Yeah.
great. So let's see. So
whole-
we had an agreement that
Yes.
basically there are no anatomical contraindications in general to edge-to-edge repair. Transcatheter edge-to-edge can be attempted in every patient, but we don't know if it works. So let's see what the people have been answering. So what did you answer? See, most audience thinks should be done both repairs and
safety.
Right, exactly.
And we have one person probably who did repair in patient A. Anyhow, so let's see what happens then. So Alison, I run your slides. Where are you? You can come to the place. Yeah, I will go up and then down.
I don't therefore know if we're crazy at the Brompton because just bringing up all of these pictures. So to point out the anatomical features, as you're right, there is failure of coaptation along the whole coaptation line and a very broad jet of mitral regurgitation. In addition, there's the suggestion potentially of a sort of possibly a cleft right in the centre of P2. But also, if you take this sort of 2D swing all the way along, we can see that there's some subvalvular tethering, there's a tiny bit of calcification in some of the anterior cords, but this posterior leaflet is very, very short, very restricted, and there's a big gap all the way along the coaptation line. So I think we thought that probably this would be challenging for us to repair. We checked anatomical screening, therefore, for potential transcatheter mitral valve implantation by assessing the annulus, which didn't seem to be too big or too small. And this was confirmed on an anatomical screening with a CT scan, just showing a tiny bit of spiculated calcification up there in the trigone. But simulating a Tendyne device into that predicted a neo-LVOT of over 400 millimeters squared and a good clearance of the hip of the device from the basal septum. So we brought the patient to theatre for a transcatheter mitral valve replacement with a Tendyne, but it was very hairy. You are quite right, the patient was very high risk. The reason why it was hairy was the end systolic dimension had gone up to 6.6. We had an EROA of over a centimetre. We had poor right ventricular function with pulmonary pressures of about 59. And more than that, we had a really low forward stroke volume. The VTI was only 8, which when we calculated that gave a stroke volume of 29, a cardiac output of 2, and now a cardiac index which was preclusive. It was less than 1. So we were a bit stuck. We put a Swan Ganz in at a blood pressure of 90. We had a pulmonary pressure of 71, so almost equating with a cardiac index of 0.9, which shows the value of hemodynamic monitoring with TOE as well. It's very close. So what did we do? We increased the heart rate and we put the patient on some dobutamine, and those two measures both increased the blood pressure and had some effect in reducing the pulmonary pressures, but also increased the cardiac index. So we felt safe. We had a moment to carry on. That had a massive effect on the LV. You can see it's a little bit smaller. That reduced the coaptation gap to some degree, and it also increased the right ventricular and left ventricular stroke volume. So we carried on. We implanted a Tendyne device, a 39 SP valve, into the annulus successfully. Well-positioned device with no transvalvular mitral regurgitation and no paravalvular leak, and this was the end result. So a really nice device function, but a lot of collaboration between the implant team at the time to support the procedure. At 3 years, the patient was living at home, independent of his activities of daily living, with no further hospital admissions for heart failure, and his blood BNP came down considerably to just over 750. On follow-up echo at 3 years, his LV ejection fraction was not surprisingly still impaired, but reasonable at 35 to 40%. His mean transvalvular gradient was 5 millimeters of mercury with no transvalvular or paravalvular leak, no LVOT obstruction, and no pulmonary pressures had come down considerably then to 35 millimeters of mercury. So here we go. The VTI stroke volume has gone up to over 100. So now all of the LV ejection fraction is coming out into the aorta.
Very good. Nice to see. Nice to see you can treat really extreme patients and with some outcome. The outcome also, which is striking, is the reduction of pulmonary artery pressure, which is obviously, now we have the answer. It was mainly related to the massive MR. So what did you do, Marianne? I already know what you do now. See, one is Tendyne, the other one is? And the winner is? Nobody knows.
So, starting from the pre-procedural TE, as you have already seen, we have a patient with a a quite good anatomy with a severe mitral regurgitation, which probably had both a ventricular and atrial component because the coaptation was quite high, with a bit thin posterior leaflet with the two or three indentation that the posterior leaflet, one between P1 and P2, the other one between P2 and P3 as usual, but also a small indentation on P2. There was an inversion of the pulmonary vein flow, but a very large area. So we decided to implant a mitral clip. At that time, we had a third generation device, so implanted a fourth XT clip on A2P2 in a medial position with, as expected, a residual lateral jet. And then we implanted a second XT in lateral to the first one in a central position with still a residual jet lateral to the second clip and with 4 millimeters of mercury of mean gradient. So we decided to use a third small clip, an NT device, in order to treat the residual jet, in order to avoid any further increase in mean gradient, which at the end was 4 millimeters of mercury gain. This was the final result, a large residual area of more than 2 centimeters square, mild residual regurgitation, and the normalization of the pulmonary vein flow. The patient was discharged during the procedure, and immediately after the procedure, he was supported by levosimendan. There was no complication, and he was discharged after 3 days, including 24 hours of CCU at home with mild MR and mean gradient of 4 millimeters of mercury. And we evaluated this patient a few weeks ago for his 4-year follow-up, still alive, near class 2, no heart failure hospitalization, a significant improvement in NT-proBNP and functional status and quality of life. Ejection fraction and LV dimension were stable compared to the pre-procedural assessment, and we had still a residual mild MR and a 4 millimeters of mercury of mean gradient. Thank you for your attention.
Thanks. So we have seen you have seen one patient with extreme anatomy. I would say the first case has been extreme anatomy, a combination of tethering. I've seen also a chordal rupture somewhere, so a bit complicated. The second one was much more straightforward, almost atriogenic with some component of ventricular, but very little tethering. So a good selection, in the two cases. Yeah. And the reason why I'm saying that is that I would like to ask again the audience to have an opinion on what do we need to do now. I mean, mitral clip is not anymore an innovative device. I mean, it's not anymore new. It's a very established therapy since 15 years in Europe. And the question is, what can we do more? What do we need more? Should we keep on expanding indications, which is one trend? What is, the point is we are using this in diverse pathologies, OCM, acute MR, and other things. Should we focus on this new indication? Should we run a trial earlier in treatment? Greg, if there was support from industry, very difficult to run. Should we improve procedural imaging? So what can we do more? So that is open to you, and we will come to these answers later, because now I'd like to take the case of Marianna as a starting point to have a further discussion with Georg. So Georg, now we have listened to Greg, who have been bringing us the great structure of a randomized trial, and as usual, US randomizes, and we are doing more real world. Still, real world registries are useful somehow, and the EXPAND registry, for instance, have been showing that combination of multiple clips in experienced hands, like we have seen with Marianna, really make the difference. You can get great results. So, let's see, after reading after seeing these two cases, the randomized trial data, what do you think the EXPAND is telling us? What are the main components of the EXPAND registry?
Yeah, very good question. I mean, first of all, there's always criticism on the randomized trials because patients are highly selected and may not present the patients we are treating in our hospitals, and therefore we need this real-world data and this registry as a complementary data set. And the EXPAND trial was a trial done with the XTR or the NTR device, so Gen 3, and the EXPAND J4 was done with also the wider clips, so the Generation 4 clips in some 1,000 to 1,100 patients. And it is very important to point out that this patient group was pretty sick, 77 years of age, and most of the patients New York Heart 3 and 4 with severe mitral regurgitation. And one important note is that in the EXPAND trial, for example, 18% of the patients were judged to be very complex disease, so meaning large prolapse, large coaptation defects, or at the risk for mitral stenosis because the orifice area was less than 4 square centimeter. But as you have seen on the slide, the results were extremely encouraging, close to 90, 98 or 91% in Gen 4, MR1 or less after 30 days and sustained over 1 year by using the clip in this very diverse patient group. And there was clinical benefit also up front. Most of the patients in New York Heart 3 and 4 and after 1 year in EXPAND, for example, 80% of the patients in New York Heart 1 and 2, and mirrored by the KCCQ score of roughly about 20 points of an improvement. So seems to be very successful also in the real world setting. Just one additional note on the clip selection, looking at Gen 4, in 88%, I think if I recall correctly, there was a selection for the wider clip, 60% in 50% for the XTW and 33% for the NTW. And in the majority of the cases, in 65% of the cases, only one clip was used. And this was not accommodated by an increase in the gradient. Gradient was 3.5 to 3.8 on average after the procedure, although most of the cases were done with a wider clip. So seems to be very good.
Georg, I want to ask you one question. So, I mean, we are familiar, I think most of us are familiar with this evolution of outcomes. So compared to the Everest 2 trial, which has been, again, an important trial because we still the guidelines are directed by the Everest for primary MR. But there is a huge difference in the success rate. So maybe what is, you think, the main component of success is, I tell you, I make a poll, you can vote, is innovation of the technology, meaning what we see now, we have Gen 4, and within Gen 4 it is because you have wider, longer, independent grasping. So what is the feature that really you think makes most of the difference? Second, is it because of operator experience? And third, is it because imaging? What is at the end your take, and maybe everybody can answer?
More forgiving core lab adjudication. No, I'm just kidding. I think it's a mixture, of course. It's a learning curve. Everest was the early days with only the small clip available, with the NT clip available, and now we have this 4 different clips we can choose from, and most of the operators are quite experienced. And this is also true, of course, for the imager. Back in the old days, imaging was very, very challenging. The machines were different. We have now different technology, different time and space resolution also in our echo machines, and we have excellent images. So it's a component out of this 3 which drives the success in that patient group. And the last point is, of course, patient selection. And just one additional point, which I haven't made before, 50% of the patients were secondary MR patients in EXPAND and EXPAND 4, G4, and they tend to be easier to be treated also with a TEER device.
Let me follow up on that. I ask Stefan. The case from Mariana. I mean, this is today pretty straightforward case. At that time, it was treated with 3 devices because it was third generation, not a wide clip device. It's almost heterogenic. So, what is your strategy today? NTW, XTW? Yeah, exactly.
Well, it depends a little bit on the size of the valve. We have to recognize that there are smaller women that may have a body surface area of 1.5, 1.6, etc. There, I would definitely go to a wide clip and a short clip, which would be an NTW, which is also a little bit high, has a higher use model in functional disease. But I also would not restrain from using an XTW in a large anatomy also, and just do 1 or 2 devices nowadays with the wider clips. So we definitely wouldn't go anymore for a 3-clip case here, but for a double W, which would actually solve the case very nicely. So I think that's the key message. We're moving down in the number of clips, and they get more efficacious actually in the treatment, even in atriogenic or in ventricular. This was also part of a dilative situation, or also in ischemic disease, which is the most difficult to treat.
And that brings to another question I have to ask you, and this will bring us also to the next chapter, which is replacement. So one of the Achilles heel of repair is durability. And we've seen, I think COAPT trial has been pretty sustained outcomes. So do you think today with this technology and with better patient selection, durability is probably better than in the past? What is your feeling?
I don't think there's necessarily better durability than in the past. I think if you get a firm grasp of both leaflets and you have a successful result, you're going to get a durable result. I think single leaflet device attachments, most common failure mode, are very rare. Perhaps they're slightly rare with G4, but you saw the durability with the first generation device. I mean, you get past 30 days, absolutely nothing happens to 5 years.
I mean, you have to divide between the durability of the device, and I think this is very safe. You have SLDA at the beginning in the first 4-6 weeks, and after this it doesn't happen. But there is, of course, progression of the disease. There's progression of left ventricular disease, there's progression of ischemic disease, and this is probably not recurrence of the disease you have treated before with the mitral clip. So that's the history of the patient. So then, what is the answer? So let's say we want to have more durable outcomes, maybe replacement may be the answer in such patients who have ongoing remodeling. There has been recently the early feasibility study trial, 3 years results from Tendyne. But it's not so comparable. At the 3 years result, they have been presented by Alison on that meeting, showed that you can completely nail down MR to almost 100% in that patient group, and there was nice improvement of the survivors, 80% in New York Heart 1 and 2, but it's a completely different animal. These are the patients we choose not to treat with a TEER device. Mortality rate is extremely high. It's more than 50% after 3 years, so we have a huge competitive risk, which makes analysis of all the other data very difficult. So it is a nice option to use Tendyne in a wide array of different MR etiology patients, in which we cannot use a repair device, I would think, right now.
Yeah, I don't think the issue is durability. The issue is how can we get more effectiveness. I think that both TMVR and MitraClip seem to be very durable if used in the right patient with a successful result. So the questions are really, will TMVR and will it being able to reliably get somewhat more MR reduction, will that lead to greater long-term effectiveness? That, I think, is an open question in TEER-eligible patients. And then will TMVR allow you to safely and effectively treat TEER-ineligible patients?
We should also go back in the journey. So if we look back into Everest, we don't remember nowadays that the SLDA rate in the early days of MitraClip was 7 to 9%. Greg, you showed 0.7%. This is a reduction by more than 90% in SLDA rate. And we also know from the mitral and the tricuspid experience that our 30-day results are predictive of further ongoing years. And this is now shown for 5 years in mitral. It's shown for 2 years in the tricuspid space. So I think this is very promising. So we have to get to the best result in the first place. And this was the difference of COAPT to all other trials, also to MITRA-FR. The initial effectiveness was the best in these trials, and it was rigorously followed. So I think that's another important point.
And again, once more, I would say important to look at this picture on the right side. 91% of patients have at 30 days 0 or trivial MR with these devices in an unselected population, with the only limitation in high volume centers. We also need to remember this EXPAND registry has been run in a high volume center, so it may not represent the full spectrum. So Stefan is doing this, which means we are almost late. I agree with you, and I think to summarize a bit the discussion, it's a matter of patient selection. There are many components. Patient selection in terms of the complexity of the anatomy, the complexity of the clinical scenario, and according to patient selection and to obviously to operator skills and everything else, we are improving early outcomes and maybe durability of this, so sustain outcomes. Okay, that is the point. Now let's see what the audience have been answering. Where should we focus? Okay, now we need some. Okay, I think that is exactly what we always have been thinking, that we should treat earlier. Now, I think, Mariana, are we going to Prague afterwards?
Yes.
Yes, so we go to the Heart Failure Association in 2 days, and this will be, we have been discussing this for ages. And the question is always, when you want to treat patients earlier, the big dilemma is, the earlier you treat patients, the more difficult it will be to demonstrate a clinical efficacy. Look at the Triluminate. Okay, this is great because we have early stage, not end stage patients, but we have little number of events. So, Greg, what is a COAPT 2 for you?
Well, I think that, that's a very important question. But I think we have to also say, when we treat earlier, are we talking about treating severe MR earlier in the asymptomatic patient? Okay, where the patient doesn't have left ventricular dilatation yet or other hemodynamic effects of severe MR, especially with functional mitral regurgitation? Or are we talking about treating moderate MR? Okay, perhaps in the symptomatic patient. And I'm actually struck in the G4 data that it looks like we're already doing that. 28% of the G4 patients had less than 3+ MR. And we must say, we currently don't have an indication to treat less than 3+ MR. So now maybe it's dynamic, and maybe at some point it was greater than 3+, but I must say, and it looks like George is chomping at the bit, I think people need to be better, and the average echo facility needs to be better at being able to quantitate mitral regurgitation. I think there's a systemic overestimation of the severity of mitral regurgitation. I think it's one of the things that led COAPT to be positive, where we required a core lab to say it was 3 to 4+, where MITRA-FR was not. I think they had more 2+ mitral regurgitation involved. So that to me is a little concerning. That being said, I think that's a great group of patients to test, but we're going to need longer-term follow-up in those patients. So we're going to need to have a primary endpoint at 5 years or longer, not at 1 or 2 years, and probably more like 1,000 patients randomized.
Excellent. So let's start collecting money to run the trial and and start this way. I think unfortunately time is short, and you have only 1 minute to summarize a long journey of 15 years. So what can we say?
This is why I prepared only one slide, so this will comply with the 1 minute. And I think what we've seen in the key learnings of knocking down MR, that we now have a 20-year experience, and in Europe, with CE mark approval, 15 years of treatment, and worldwide we've seen now across 190,000 patient procedure experience. We have discussed the extreme safety profile, and I would like to add that there's always a risk to benefit ratio that has to be seen. So the safer procedure is, and we just alluded to it, it's now below 1%. 1 month mortality, which is below the natural 1 month mortality, which may be estimated at around 8%. So we are very close to an excellent situation where taking a pill and doing a procedure, and Greg said this already, is not a huge difference anymore. And if the procedure, of course, also is effective. We've seen this very low mortality. We've seen one of the highest MR reductions now with 91%, something that has been seen and criticized. The success rate in Everest 2 was 77%. We're now across 98% success rate, going down to moderate, mild, or none, and 91% mild or none. And I think this is also very interesting. And Greg showed it nicely. We have durable 5-year results, which is also something that had been questioned 5 years ago. And now we have the data to support this. On the other hand, and we discussed this a little less, is of course we have an alternative, which is replacement. Actually, the tendon that we've seen was done in a very, very sick patient. So congratulations to you, Alison. And this is the only commercially available device that we have in our toolbox. Also here, we now have 1,400 patients. We shouldn't forget this. It's been a long journey, 10 years, but it's the largest worldwide human experience. I can announce that the Summit MAC arm, and this may be an ongoing indication that is additional to no TEER, is the combination of stenosis and regurgitation, which we are unable to treat by TEER. The safety has low procedural adverse events, but we have a negative patient selection. So only those who are not eligible for TEER go into the replacement. So of course here the situation and the mortality still is higher, but this will decrease. And we already see this from the TENDER registry, which has now included 270 patients that actually high volume centers exceeding experience of 10 tendon implants have a much lower mortality than those centers who start with their first 2 or 3 situations. And we have seen the 3-year follow-up and the sustained MR elimination, which is, of course, the stronghold of TMVR. So I thank the whole panel.
1 second.
And
because
we have some.
No, we didn't answer a question from the audience. So I think we take a couple of minutes more. I think it's not good. Very quick. I need an answer like this. Okay. Heart failure patient with cardiac index 1.9, severe MR, shouldn't be better candidate for LVAD to you?
Could
yes
have.
or no?
No.
Why?
Because we removed his MR.
Well, because the guy is still alive 3 years later without an LVAD. It's not such a nice. So maybe yes, but in retrospect, no. I think you did a good job.
Right ventricular issues.
Yeah, and also there was degenerative disease. There was calcium.
Yeah,
the
yes or no?
yes
or no? That was LVAD. Yes or no? That's it. The other question is. Third clip should be mandatory to eliminate. Should we eliminate MR, or is better to leave some MR as a ventilation, as a here? Just I like ventilation.
No. We should obtain an optimal result.
Very
1
good.
plus or less.
Okay. Target of therapy is abolish MR, knock now MR. This is the topic of the day. So for those who are still thinking that having a backflow is positive, maybe in the early stage, in the first 12 hours, yes, but not afterwards. Last, for how long should we give titrate medical therapy for you very quick in your dream? How long should be guideline direct or goddamn directed medical therapy be up-titrated before thinking about?
Yeah. I mean, within 4 weeks, you should be able to titrate all 4 classes of drugs.
4 weeks. 4 drugs, 4 weeks after that.
Yes.
Go.
Combination is more important than total titration, and this has been FDA accepted in the last 2 years. So there will be a change, and COAPT would look differently now than it was before. Because we're 3 minutes over time, I now take back the anchor person, and I now close this session so that we can have an additional congress with other topics too. Thank you very much for your attention.